Welcome everyone. This is Dr. Sharad Jaitly from New York. Thank you for watching, learning, and sharing on MuniMeterHealth.com, your favorite website, which is dedicated in educating you and teaching you the human heart and its illnesses. We are on Facebook and of course on YouTube, as you know, and hopefully we are seeing you on both, preferably because you certainly want to use one backup app over the other, just in case the one is not operational. Anyway, thanks again for your continued enthusiastic interest and support in my cause of spreading the education freely to all. And of course, bringing about the awareness of the human healthy heart to everyone. Once again, thank you for associating with MuniMeterHealth.com. Without any further ado, I always say, let's delve into the subject of the matter, and the matter of the heart being, today, right ventricular infarct, RVI. Now, as a principle, just remember that right ventricular infarct, specifically now for the medical students, the trainees, the residents, the fellows, or people who are just about to take the boards or recertifying for the boards, just refreshing your memory and remember, right ventricular infarct is always associated with inferior wall infarct, inferior wall MI. It's never with an anterior wall MI. So one thing for sure, that all inferior wall MIs will be associated with right ventricular infarct, but not all inferior wall MIs will have RVI. So in other words, right ventricular infarct will be present in inferior wall MIs only, but not all inferior wall MIs may manifest as right ventricular infarct, just so that we know. Okay, because the inferior wall also is composed of left ventricular portion as well. So you may not have a right ventricular infarct in that setting. Now, obviously, the suspicion is high in an inferior wall MI. Remember, the clinical features are such that whenever you suspect right ventricular infarct, you must demonstrate that there is either a drop in blood pressure, a drop in cardiac output, and or a severe drop in pulse oximetry, like there's a systemic hypoxia present. And this may be out of proportion. The hypotension, the low cardiac output, and the hypoxemia is out of proportion in a setting where you have an inferior wall MI on an EKG. Now that lends suspicion, strong suspicion for a right ventricular infarct. Remember that. Now, having said that, let's understand what the pathophysiology is. But before we do the pathophysiology, we need to know what the coronary anatomy is. So here I am going to draw, for the sake of it, what the human heart looks like externally. For instance, this is how the plumbing goes, if you will. We have an outside of the heart like that, and then you have the aortic valve leaflets here, and this becomes your ascending and the arch of the aorta. If you were to look at the arteries, the arterial supply will look more like this. You'll have a left main and then dividing into two, and one will become the circumflex, which will go around like this, and then obviously to the back of the heart, if you will. Left anterior descending will be coming down towards the apex in this fashion. And then of course there'll be several branches, very important branches, which will be given out from these vessels, and they will tend to again even meet with each other on the other side and supply the entire heart. Now from the right coronary cusp will arise a right coronary artery, if you will, and that courses closer to the right side of the heart border until it meets at the apex towards the left ventricle. There will be important arteries here as well coming out, especially the atrial nodal arteries, and then the posterior descending artery, which is a very important artery, and then several other branches which will be given out to supply the chiefly the right atrium and the right ventricle. So having said that, now let's understand the pathophysiology. In pathophysiology, if you were to look at, the heart will behave in the following fashion. Here's the heart. The inside of the heart will look like this. We know it's a four-chambered heart, obviously. And therefore, one has to see what happens here. One, the right-sided pressures, specifically the RA, the RV, and the pulmonary artery pressures, they will be elevated. So pulmonary artery pressures will also be elevated. Now, pulmonary capillary wedge pressure, which is the wedge pressure here, that is reflective of the left atrium or left ventricle and diastolic pressures. They will be low. So the pulmonary capillary wedge pressures will be low, but these pressures will all be elevated. So if you were to put a Swan-Ganz catheter or a pulmonary arterial catheter, if you will, those catheters will have setting in that setting they will show evidence of all these pressures on the right side being elevated, while ironically the pulmonary capillary wedge pressure will be low. So what have we inferred so far? We'll see a blood pressure which is low, we'll see a cardiac output which will be low, and a pulmonary capillary wedge pressure will also be low. So in a setting like this, one obviously thinks maybe there is IV fluids or intravascular volume, if you will, is depleted in that individual. But that's not the case alone, because you'll have an inferior wall MI in that setting to supplement that diagnosis that there is a right ventricular infarct that is being suspected very, very prominently. So in other words, in a setting of inferior wall MI, you have a low blood pressure, a profoundly low cardiac output, and a profoundly low pulmonary capillary wedge pressure. Think right ventricular infarct, in other words, okay? Specifically in a setting of inferior wall MI, as I said. Now, pathophysiologically, having said this part, let's understand angiographically how these obstructions happen. If you were to cath a person like this, you will see that there might be a proximal RCA lesion, or there might be a distal RCA lesion. Now, this being the right coronary artery, you will have a proximal RCA lesion. That's one type of the lesion. The second type of lesion is a distal RCA, if you will. And then a third type of lesion that can occur in this being the circumflex, will be in the circumflex as well, because that also supplies the, if you were to look at, it's the back of the heart, like here, mostly the inferior wall, and it comes out here. So on a cath, if you were to look at, what will be the findings? The cath findings will be the following. You will have a proximal RCA, for instance, as I said, and that will manifest as on an EKG the following way. There will be an ST elevation present, and the T waves will be upright in a proximal RCA. When you have a distal RCA involvement, at that point you will have no ST segment change, in other words. So there is no ST segment change, I will say like negative, and the T waves will be still upright. So there is no change on the EKG at all. And the third pattern, as I said, will be the circumflexia, which is the third part, and that is the left circ, which has an obstruction, and that is leading to right ventricular infarct. You will see ST segments will be depressed and the T waves will be inverted. So it's a very distinctive pattern on an EKG in a cath, correlating with the cath findings based on an angiography that one performs. So just to regroup quickly, proximal RCA will show ST elevation, which will be looking like this, mostly. Distal RCA will show no changes, so the ST segments will be just normal, whereas the left circ will show an ST depression here and a T wave inversion. So both will be depressed here, and these will be elevated here, and the ST and the T waves will be upright here. So this is quite a distinctive pattern, as I said, angiographically correlating with these three different types of lesions. Having understood that, how is the treatment plan gonna change or change the outcome? The clinical outcome is really dependent upon how quickly one can recognize it, and two, how quickly can you perform your procedures. Well, obviously, as soon as you recognize, based on the suspicion, as I said, whenever you have an out of proportion blood pressure drop, a cardiac output drop, a pulmonary capillary wedge pressure markedly low, like 4 or 5, you must start infusing fluids in a setting of inferior wall MI right away. One, because you'll be able to improve the afterload into the left ventricle. Because remember, the right ventricle preload is extremely low, and therefore you want to improve the right ventricular afterload so that that becomes the left ventricular preload, and therefore you should be able to improve the cardiac output in that setting. So that's one. Second, you'll start to use IV pressors or inotropes, if you will. AV sequential pacing is very required, because remember, this portion of the right ventricle is akinetic or dyskinetic. So now if you're given a pacing wire here in this region, the chances are you will be able to improve the ejection fraction of the right ventricle and help unload a lot of blood volume into the left side of the heart. So AV sequential pacing is of paramount importance wherever it's indicated, wherever it can be performed. And fourthly, but not the least, is the reperfusion. You got to open up these arteries, right? So you have to do the cath, quickly take the patient into the cath lab and start the reperfusion mechanism. So reperfusion is very, very important. It's paramount importance here. So depending upon where the obstructions are, there are multiple obstructions like the circ lesion and an RCA lesion. You end up giving angioplasties or PCIs to both, and you will be surprised that you will be able to improve the right ventricular function rather so quickly. And invariably, the left ventricle is not involved, so the chances are you should be able to get the cardiac output going rather quick. So it's very, very important to recognize the right ventricular infarct in a setting of inferior wall MI. And just a quick summary and a quick list of caveats. Number one, suspect RVI in a setting of inferior wall MI when you have profoundly low blood pressure, profoundly low cardiac output, and a profoundly low setting of pulmonary capillary wedge pressure. Number one. Two, not all inferior wall MIs will have RVI, but all RVIs will have inferior wall MIs. Number three, whenever you suspect a right ventricular infarct in a setting of inferior wall MI, having seen these features, start doing an EKG with the right-sided chest leads. And these are the right-sided chest leads when you do V4R, V5R, and then you have V6R. So these are your chest leads which are going on the right side, just corresponding to what your left precordial leads are. Do the right-sided leads, V4R, V5R, and V6R. And they will show you ST elevations continuously in those patients. And when you have these patients who have RVI and the ST elevations present in the right-sided chest leads, you have clinched your diagnosis. And last but not the least, do not give nitroglycerin to a patient whom you suspect a right ventricular infarct, because that patient is going to bottom out and will drop the blood pressure and cardiac output. So this could be a board question directly, indirectly. They might say, hey, look, all drugs are indicated except. And you could say nitroglycerin is the only, nitrates should not be given. Any preload reducer you don't want to use. You don't want to use any diuretics. You don't want to use a nitroglycerin, because these patients are very, very volume sensitive. And all it takes is a little bit of vasodilatation, especially in the veins or in the preload sector. The chances are they will drop their blood pressure rather precipitously and can lead into a highly impending cardiogenic shock, maybe sometimes an irreversible cardiogenic shock. So in a nutshell, I've talked to you about the right ventricular infarct on this short video. Hope you found this very interesting. And before you take your boards, your exams, your tests, and go on for your rounds the next day and meet your professors, hopefully you'll have a lot of information up your sleeve to discuss that. So enjoy and stay tuned with MuniMeterHealth.com. And please tell all your friends, your colleagues, and your residents and trainees that, look, here's a cardiologist who's dedicated to teaching you across the globe in my stage and phase of my life, where I can actually impart the knowledge sitting in my studios here, and while you're working on your smartphones and on your laptops and iPads. Good for you, and stay tuned until the next video, and hope to see you soon. This is Dr. Sharad Jaitly. So long. Bye.